Thank you and good morning. Just in advance of commencement of this committee meeting, I'd just like to note that in private session of this committee, Deputy Rabbitte, Senator Warfield and Deputy Neville and I raised the issue of a lack of response from TUSLA, the Child and Family Agency, in relation to questions posed during the course of a public debate on this matter during recess on the subject of hide and seek, and specifically the issues raised in the airing of that programme. During the course of our private session, the committee asked that this be raised in public session for the purposes of highlighting that we are disappointed we haven't had a response from TUSLA, and following this meeting the Secretariat will contact TUSLA in order to provide us with a reasonable response to the matters raised during that public session, up to and including the number of creches that are under investigation, that the 37 that have been mentioned on several occasions. And I think it appropriate that we mention that in public session rather than behind closed doors. So I just wanted to mention that in advance of commencing our meeting this morning. So I'd like to welcome members and welcome you back to the Committee on Children and Youth Affairs, and indeed our guests for joining us this morning. The purpose of today's meeting is to meet with representatives of the Child and Adolescent Mental Health Service, or CAMS, and Jigsaw and the National Centre for Youth Mental Health to discuss youth mental health. On behalf of the committee, I'd like to welcome Mr. Jim Ryan, Assistant National Director and Head of Operations at the Mental Health Service in the HSE. I'd like to also welcome Professor Brendan Doody, Consultant Child Psychiatrist and Clinical Director of Lindara Child and Mental Health Services, HSE. I'd also like to welcome Dr. Joseph Duffy, Chief Executive Officer of Jigsaw, as well as Ms. Sarah Cullinan, Director of Services in Jigsaw. Before we commence, in accordance with procedure, I am required to draw your attention to the fact that by virtue of Section 17(2)(l) of the Defamation Act 2009, witnesses are protected by absolute privilege in respect of the evidence to this committee. You are directed You are directed that only evidence connected with the subject matter of these proceedings is to be given, and you are asked to respect the parliamentary practice to the effect that, where possible, you should not criticise nor make charges against a person or entity in a way as to make him, her or it identifiable. And members are also reminded of the long-standing parliamentary practice to the effect that members should not comment on, criticise nor make charges against a person outside the House or an official either by name or in a way as to make him, her or it identifiable. May I please remind our guests, as I've already reminded the members, to please switch off your mobile phone and put them into flight mode, as they will interfere with the sound system and make it difficult for those watching to pick up what you're saying. We wouldn't want that. I also wish to advise you that any submission or opening statement that you've made to the Joint Committee will be published on the Committee's website following this meeting. After your presentation, of course, there will be an exchange of questions from the members present, and I would like to note with thanks the presence of Deputies Buckley and Ellis, who have joined us this morning in addition to the ordinary membership, so thank you for joining us. I now call on Professor Doody and Mr. Ryan to make your opening statements, please.
Thank you, Chair. So good morning, Chairman and members of the committee. My name is Jim Ryan and I'm the Head of Operations in Mental Health in the HSE. Thank you for the invitation to attend the committee meeting on Children and Youth Affairs to discuss youth mental health. I'm joined today by my colleague, Professor Brendan Doody, Child and Adolescent Psychiatrist and Clinical Director of Lindara Child and Adolescent Mental Health Services. I'm pleased to be here today to speak to you about mental health. We did submit a briefing paper in advance of today's meeting, so I will confine my remarks in this statement to give you an overview of HSE Youth Mental Health Services. Since 2012, a total of $2,008 million additional funding has been allocated under Programme for Government Funding to HSE Mental Health Services, including youth mental health. The HSE provides and funds services for young people in community, child and adolescent mental health teams and inpatient facilities up to the age of 18. The fact that the Mental Health Act defines a child as an under 18 impacts on the legal and organisational response to youth mental health. HSE Mental Health Services' main priority is providing care for young people in secondary care mental health needs. Members will be aware of a number of national policies and strategies which inform the direction of mental health services for young people, including a vision for change on national mental health policy, which is currently being updated by the Department of Health, Connecting for Life National Strategy to Reduce Suicide 2015 to 2020, and Sláinte Care. We have also been involved We've also been involved and informed by the recent National Youth Mental Health Task Force Report 2017 and the report of the Joint Committee on the Future of Mental Health Care 2018. Youth mental health services in Ireland are integrated with primary care, acute hospitals, disability services and a wide range of community partners. Services are provided in a number of different settings, including health centres, day centres, inpatient units and sometimes in the service user's own home. Regionally, the 9 community health organisations have responsibility for the delivery of community health care services within their respective programme areas. While the Chief Officer has overall responsibility, the Head of Service for Mental Health in each CHO, in conjunction with the Executive Clinical Director, is responsible for delivery of mental health services across the CHO area. In terms of tiered level of services, the HSE reaches the wide population in a number of ways, including our Little Things campaign and more recently our digital mental health service improvements. Interventions at primary care level are important to support young people when they initially start to struggle with mental health issues. Many young people can be treated at primary care level and make progress without attending or needing access to specialist mental health services. Primary care services include GPs, Jigsaw and other NGO service providers, primary care psychology services and counselling in primary care, which is available to those over 18. Jigsaw services are fully funded by the HSE and they see young people up to the age of 25. There are 13 Jigsaw services in communities across Ireland providing mental health support to young people, and the work continues to develop 2 new Jigsaw services in Wicklow and Tipperary. CAMS provides specialist mental health services to those aged up to 18 who have reached the threshold for a diagnosis of moderate to severe mental health disorder that requires the input of a consultant-led multidisciplinary mental health team. CAMS inpatient units offer assessment and treatment to children and adolescents up to the age of 18 with severe and often complex mental health difficulties. For those aged over 18, those services are provided by general adult community teams and inpatient units. Approximately 2% of under 18 population will require a CAMS intervention at any given time. In conclusion, mental health services for young people have improved significantly over the last number of years, with an emphasis on early intervention, but also on services for those with severe mental illness, using models of care supported by clinical evidence base. Notwithstanding the improvements, we are very aware of the continued need to further develop services and deal with challenges including consultant vacancies, and will continue to work with all stakeholders, including the Department of Health in this regard. This concludes my opening statement.
Thank you very much, Mr. Ryan. I now call on Dr. Duffy. Please make your opening statement.
Good morning, Deputy Chair, Deputies and Senators. Jigsaw warmly welcomes the opportunity to contribute to the vital work of the Oireachtas Joint Committee on Children and Youth Affairs. We all know that adolescence is a time of huge change and upheaval. The journey from childhood to adulthood is complex and challenging, and for many young people, this journey can be particularly tough to handle. Jigsaw's vision is an Ireland where every young person's mental health is valued and supported. Jigsaw was established in 2006 as Headstrong to meet an identified gap in service provision for young people struggling with their mental health, possibly with emerging mental health issues, who did not require the support of specialist mental health services. Previous research by Jigsaw has shown that 1/3 of Ireland's young people have experienced mental health difficulties. Our evidence and our experience of working with young people tell us that many across Ireland struggle daily with anxiety, low mood, stress and isolation. The cost of this mental health crisis in Ireland to Ireland's economy is a staggering $8.3 billion a year, not to mention the devastating personal cost to an individual's quality of life and their physical well-being. We know social inequalities are associated with higher risks of mental health difficulties. The more unequal the society, the greater rates of distress. In Ireland, this is particularly relevant given the gap between rich and poor. The gap between rich and poor is growing, and the numbers of young people finding themselves homeless is on the rise. The young people we see tell us about how they feel under tremendous stress to succeed and excel at school, at home, on the sports ground and in social groups. Jigsaw supports thousands of young people across Ireland every year through our community-based youth mental health services, through our work educating parents, teachers, young people, and through our information and guidance at jigsawonline.ie. Since Jigsaw was founded, young people have been involved in helping us to develop and design our services. We now have a youth advisory panel in each of our services and in the National Office. These panels are made up of young people aged between 16 to 25 who may or may not have had experience of the mental health system, but who are all passionate about this area. Our youth advisors asked me to emphasise the following to you today. A holistic approach is needed to address the causes of mental health difficulties. Young people are worried about big issues in society, such as inaction over climate change, increased homelessness, academic pressure, and the pressures on minority groups. More specifically, they're concerned about wait times for mental health support, gaps between child and adolescent and adult mental health services, and the cost of private therapeutic support. Awareness campaigns are not enough. Young people respond better to information from their peers. In Jigsaw, we believe in intervening early with mental health difficulties, offering a therapeutic services to young people at a primary care level. We also believe in listening to each young person's judgment of their own needs, hence we have a service with no lower threshold. We aim to construct an understanding of what is happening in the young person's life with them, rather than solely through the objective assessment of the clinician as the mental health expert. We know that there's no easy fix or a miracle solution for mental health problems, because these are complex and challenging. But there is much government and policymakers can do to better support young people who are experiencing mental health difficulties. That is why we're calling for an increased focus on mental health services that are proactive, community-based, integrated and early interventionist in nature. Investment in keeping people well, rather than waiting until they're very unwell, has the potential to save lives and save significant financial resourcing. Investing in early intervention, implementing the recommendations of the National Youth Mental Health Task Force Report 2017 will contribute to making a real meaningful difference to the mental health of Ireland's young people and give them the best possible chance of a full and healthy future. We in Jigsaw very much welcome this opportunity to discuss the issues that we've raised further during this meeting. Thank you for the invitation to participate in this process.
Thank you very much, Dr. Ryan, and thank you both for your opening statements in this important discussion before the committee this morning. I'd like to call on Deputy Tom Neville, who is first to indicate.
Thank you, Chairperson, and thanks to the witnesses for coming in, or the guests, should I say, for coming in. Just a number of questions. I'll fill the first to Jim Ryan. You spoke there about Vision for Change being updated, Jim. Have you given any date, or have you been given any date, or when that may actually happen, when the full document will be updated? Where are they in relation to implementing a 24/7 call number? I know the Minister was speaking about a 24/7 type number that will be used. Pathfinder is something I'm working on as well behind the scenes in relation to the different departments. I have to get an update on that, so that's more on the government side. I patrolled about 2 weeks ago with Limerick Suicide Watch for 4 or 5 hours in Limerick. It was an extremely humbling experience. I can't find another word for it. There was one intervention while I was there. I didn't witness the intervention. It was actually at the other side of the city with 2 teams out. But we did witness, there was people, who were there, who felt low, who wanted to speak to somebody, and then they went away about their business. But obviously there was one intervention that took place. These groups, the type of work that they're carrying out, I know they're across the country in other areas, is unbelievable. My own experience of it, whereas you would be on the bridge patrolling or on the bridges patrolling, there's a jovial kind of atmosphere between the volunteers, because that's how you deal with these type of things. But there is that sense and that nervousness there all the time that you're watching, and you've almost, like, for want of a better word, there's butterflies in your stomach for those 4 hours while you're out there. And I was just shadowing. I'm not a qualified patroller. But what I want to know is, have the HSE been interacting with these groups, these patrol groups, in relation to what their findings are, in relation to the data that they're gathering, the interventions, the type of interventions, and the recommendations that are making, the tangible recommendations that they may be making in relation to deterrence in these areas. They're doing all they can, but I want to know, are the HSE and the other bodies doing all they can to communicate with these people? Because some of the things they cited to me was that, in their experience, this is anecdotal experience, was that some of the patients, when they were, we say, taken by the emergency services to the hospitals, they may come out of the hospitals and actually it may be a reoccurring intervention. What they did cite was having somebody qualified on site, that somebody would be there straight away, because It's the actual time from the intervention to the emergency services, that lag or that gap, is where I believe from speaking to these people that the system needs to be, Jigsaw there spoke about being proactive and actually reaching out to these people as opposed to being reactive. Now that's quite difficult, I do take on board that's quite difficult, but somebody in a mental health situation, oftentimes from experience from speaking to people, it's actually trying to make the call. It's very difficult. They need someone to make the, to help them to make that call, to reach out as opposed to reacting. It's all very fine saying to somebody, oh, go get help. But sometimes the person who's in the situation needs somebody to take the lead and go, would you like me to help? Would you like me to make the call for you? And that's what I'm trying to look at the system, particularly at this acute emergency level, when there's people in such distress, that there's that interlink between the emergency service and where it's taken place. I'm just citing it as an example, and I'm coming from an area where I don't have a huge amount of knowledge. Like I said, I only spent 4 hours with these people myself, citing that. So I'd like your take on that. In relation to money spent in the HSE, in relation to new monies coming in from the government, was all that money spent in 2018, or was some of it handed back? The recruitment, we know there's been recruitment challenges in the mental health services. Has anything been done to overcome those recruitment challenges since the Mental Health Committee sat? We identified a number of roadblocks that were happening in relation to the recruitment process. Has there been any changes made to that recruitment process, or any improvements, and if so, what they are? In relation to Jigsaw, I've visited Jigsaw in Limerick as well. Fantastic service of what's being done there. Just you mentioned there in relation to what Jigsaw is looking for, proactive community early intervention. What type of works from your experience has been done on stigma? Is there any push or move on stigma? Me, myself personally, I do take comfort with some of the younger generations that stigma isn't as prevalent as what it would be in the older generations, but I don't want us to take our eye off the ball, because it still is there. It still is a subcurrent. And I would just like to know what Jigsaw's experience or what their advice would be in any future campaigns in trying to combat stigma. Thank you.
Thank you, Deputy Neville. Who'd like to start?
I might start if that's okay.
Go ahead.
So the date for the Vision for Change refresh, we understand that it's in the final stages. It's a Department of Health document, but we understand it's in the final stages of completion, and I'd expect it's probably likely to be published before the end of the year. But I mean, it's with the department at the moment. The 24/7 call number, we expect to be making an announcement. World Mental Health Day is in early October, and I understand the Minister Daly will be making an announcement about that 24/7 call number then, as he has outlined earlier. And Pathfinder, as you've said, is a challenging initiative because it's cross-party or cross-government. So we're waiting for that to happen as well, because it will impact on a number of the recommendations from the original Youth Mental Health Task Force report. In relation to, I don't have the details in relation to the Limerick, to the patrols in the Shannon. I can get details on that, but it's more the general question.
My question was general, because I know these patrols are happening in other parts of the country. So from your point of view, it's going to be a top. Is there some sort of relationship with these bodies?
In some parts of the country there is, but it's not. It hasn't come to me.
It's not a formalised relationship.
No, it's not. What I can do is to get perhaps more information, particularly from our National Office for Suicide Prevention, my colleague there, John Meehan, and I can report back to the committee, because they would have a more day-to-day relationship. But I mean, the country has responded in a wide variety of ways to suicide and to the threat of suicide, and so we would try and be supportive within resources, and also, I suppose, making sure that the models that are being used are appropriate and evidence-based.
Yeah. And I would back up that, like, that the figure in Limerick has gone from 23 per 100,000 to 15 per 100,000 in the last 3 or 4 years. Now I don't have any evidence of why that is happening. I would make the assumption that a number of initiatives are happening, including those patrols to help.
Yeah. And internationally, it can be difficult to know what one initiative makes a difference. It's a combination. It's more like a matrix response than it is a single initiative. The money spent in the HSE, so I can assure you that all of the money that was allocated for mental health has been spent within the mental health services. The recruitment challenges that you've mentioned, and as you know from the previous committee, they still remain. Nursing, we have invested HSE funding in relation to additional both undergraduate and postgraduate nurses. So come 2020 September, the output of nurses, there will be an additional 60 nurses. It will go from 295 this year to 350 next year. And that's because we've invested actual HSE mental health money to actually pay the colleges to put through more undergraduate nurses as well as the postgraduate. We would hope that that will make a difference, because we have a lot of challenges in that regard. So the consultant challenges...
While we're on that subject, has the process, the recruitment process, changed in any way since we spoke last in the Mental Health Committee? There's something like 26 to 29 steps we identified to hire a psychiatric nurse. Has any of that process changed, or any of the recruitment processes changed in relation to mental health services?
Well, as a result of a lot of unrest around the process, Minister Daly had raised this as a significant issue with us, and with the HBS, which is our recruitment partner. And I don't think that there's been enormous change. We have been affected by some of the recruitment issues from the point of view of staying within budget, etc. But I think that we have tried to streamline the system to the best of our ability, making sure that we still remain within the licence that we have as a recruitment agency. So that's one of the challenges.
Is there any way you can give me, or be able to provide a breakdown of those improvements in the process?
Maybe
I'm not asking for it today.
Absolutely, I will come back to you on that, and to the chair, if that's okay.
Okay, no problem.
And the final one, maybe you want to deal with that around the stigma, maybe through...
Just one final question for yourself. In relation to consultant psychiatrists, has anything, from the HSE point of view, what has been done to try and overcome that challenge?
So there's and Professor Dooley may speak about that. So a number of things. We've actually had some success recently in recruiting consultants in parts of the country where we have found it difficult. Okay. The northwest, the southeast. Yeah. Part of that can be because of the efforts that are being made. It can take 6 months sometimes for people to change their life circumstances, etc. But also, you'll be aware that the Minister for Health has spoken about the need to look at the differential between the new recruits and existing consultants. So I think the mood music may be changing a little bit on that. The other thing we're doing is we're looking at putting in HST or higher support training posts, so that we would be growing consultants over a number of years. Because a little bit like nursing, sometimes we put in new developments and we're essentially denuding our existing services. We're moving people around as distinct from increasing the pool. And
was there any key factor, Chair, was there any key factor you identified in consulting those, or in hiring those consultants, or recruiting those consultant psychiatrists, that you put your finger on to go, you know what, this is how we actually got this candidate? Or is it just idiosyncrasies with each candidate? Because what we're trying to do is find a trend here that we can actually hit.
Absolutely. And we're trying to find the trend. Our challenge often the time is that if you understand one area, you understand one area. So if you have somebody who wants to work in the northwest, the southeast is very different.
So it's gone back to the panels?
It's gone back to that. Yeah.
Okay.
Maybe through the chair, Professor, if you want to say anything on that.
Just to echo what Jim has said, is that there has been, I suppose, a major expansion in child and adolescent mental health services over the last 8 to 10 years. And obviously that has meant obviously increase in there's been a significant increase in the number of consultant child and adolescent psychiatrists. So what you have is, on the one hand, you're developing new services, creating new posts. You at the same time have a turnover of the existing with retirements. And what happened is a number of years ago, a lot of higher trainees left the country to take up employment abroad, opportunities abroad. The reality is there's a worldwide shortage of child and adolescent psychiatrists. So, as I said, they're very mobile, and there's worldwide opportunities. And consultants who have left actually have, or those who would have been eligible to take up consultant posts, if they go abroad, would go to either Australia or to Canada, where the destinations, I suppose, most frequent destinations. On a positive note, I think the intake into higher training places in child and adolescent psychiatry is now kind of the demand is exceeding the number of places. that, again, training, it will take a number of years before all these, as I said, higher trainees complete their training. So their basic training, 3 to 4 years, higher training, then a further 3 years. So there is going to be a lag with regard to the new consultant posts coming on stream. So that is one factor. Then the next factor, I suppose, then is factors which may be geographical factors, again, which would be across all various disciplines. And you see this in other countries, that you may have recruitment, there may be geographical factors as well as service factors, and there's a lot of different factors that one needs to consider, and what may apply in one area would not necessarily be the issue in another. And another, I suppose, something is that I think we are becoming more attractive for consultants from outside to come and work here. And I suppose that we may be looking at some consultants who work in the UK who are now looking at coming to Ireland and taking up posts here. And that even when we're looking at recruiting from recruitment agencies to fill posts on a temporary basis, that the recruitment agencies are saying that, let's say, consultants who would have been in the UK in locum positions, or European consultants who may have chosen particularly to go to the UK, are now looking at Ireland as an option. So I think it's going to be, in other words, before we fill all the posts permanently, it is going to take a number of years. It takes, again, it is the demand, and as we create new services, and again, this can be the point. This is something we've also experienced, is as we've created more specialist services, what happens is the consultants who will existing consultants take up these posts. So what happens is that we fill a post here, but then actually what we have is that creates a vacancy somewhere else.
Sorry, Chair, just to ask on that. Has there been any change to the panel structure? You know, the people go on panels and it's quite rigid. Has there been any change or any movement on flexibility on panels? And secondly, just in relation to consultant psychiatrists, again, it's just from my own information, and correct me if I'm wrong, but if somebody has a consultant psychiatry background in adult, are they able to move across to adolescent, or is there a blockage there, or what's the? If you can.
To take up a consultant post, the requirement is you're on the specialist register, and the register is you're either on the specialist register for adult or you're on the specialist register for child and adolescent.
Right.
And again, that sometimes can be issues for consultants coming from certain European countries about their eligibility to be on the child specialist register. So in other words, to take up a consultant post, you have to be on the specialist register. So in other words, you're either adult, so the major divide is adult and child and adolescent.
And just for my lack of medical knowledge, what's the rationale behind it? Is it because there's such a difference between child and adolescent and adult that one has to specialise in either or the other?
The training diverges. You do a basic training, so the training is broken down into your basic training and your higher training. So the basic training is generic, it's for everyone. And then at the end of your basic training, you then specialise. And I suppose it bifurcates into adults and to child.
How long does it take to specialise?
It's 3 years of higher training. 3 years.
So if somebody was an adult consultant psychiatrist, it would take them 3 years to specialise in child and adolescent, yeah? Well,
what would happen if you wanted to do that, it may not necessarily, that is something if you want to do. Now, there's a small number of kind of dual-trained consultants, and again, how that is done would be done with the college, and the college would have specific requirements as to, in other words, to achieve the necessary, obviously, training and expertise, so that they would also be eligible to register on the child specialist register as well.
Okay. And just on the panels and stigma, they're the two.
Yep.
Yeah.
So, in relation, panels are not necessarily not an issue really for child psychiatrists, because they're for very specific posts, and you have to go to CAC, which is the Consultants Appointments Committee. So they're very specific posts. The panels for nursing are still generic nursing panels. We have tried both. We have tried local recruitment at different times, and we've tried generic. The benefit of the national is that it's one panel. The disadvantage is that if somebody says, well, I want only to work in Limerick, or I only want to work in Dublin, then they may wait until such time as a vacancy comes up there, and meanwhile the panel gets stopped. So there are challenges in that. We have now put in place, if you can't get somebody from a national panel, you now can recruit through a bespoke local panel.
Okay. Very good.
Thank you.
Thank you for that.
Thank you.
Are there any other? Yes,
Just the
please. Dr.
Take
Duffy,
the,
please.
talk about stigma.
Yeah.
Yep. Stigma is, I suppose, it's very much a live issue in, I suppose, our experience of services. And I suppose the way we respond to it is by looking at it, the stigma and knowledge within different groups, so that we would work particularly with young people in terms of the work we do in schools around peer education and our experience, and indeed the evidence in terms of doing that. It's very effective in terms of creating that knowledge base and then getting young people to connect with other young people. So there's a really strong peer influence that's there. There's also strong influence in terms of awareness and training that's provided to adults, be they specialists working with young people already or to parents working with young people. So we would do a lot of work with campaigns. There's a campaign at the moment with one of our sponsors, Lidl, around One Good Adult. So that's about promoting that wider piece. So where we can target, there's good evidence and good experience in terms of that being really effective. The difficulty is that we're now seeing there's I suppose generational shifts and changes. So young people who are involved and educated and aware have much more knowledge, and their parents are beginning to have that. But then there's also, I suppose, wider groups within the community that we find at times that there'll be difficulties. One anecdotal story is that when we were looking to establish another office for a particular jigsaw service, we came up with a difficulty with a landlord who actually didn't want to have a mental health service there. So we tried, we brought them to another service, we did everything we could do. So in many ways we can address stigma where it's very clear or where it's fairly obvious with the wider group, and that's successful. But then there is pockets of it. So it's a continuing issue, but we put, I suppose, a fair amount of resources, and particularly the work that we would do with any of the fundraising sponsors would be, a lot of that work would be on awareness raising.
Just to thank everybody for their answers. Appreciate it. Okay. Thank you.
Just to indicate to members, and just for the benefit of Deputies Ellis and Buckley, I'll take members of the committee first, and then I'll come to you if that's all right, as is the custom. So Deputy Rabbitte is next, and Deputies Chambers and Sherlock, followed by Deputy Ellis and Buckley. Those are the people who've indicated.
Thank you, Chair,
Deputy
and thank you all for your presentations there this morning. I suppose I'm going to break it up into three different sections, if that's okay. So, Jim, I think that the first one, and to yourself, Professor Brendan, it's broken, like, what makes up a team for youth mental health? Can you tell me, and if we can do it over and back, if you don't mind, so what makes up a team, okay, and how many teams is there?
Okay, so if it's okay, we have 71 child and adolescent mental health teams. So I'll give you, if it's okay, I'll give you the Vision for Change. It says there should be 13 members on a team.
Yes, all right.
We would have about 60% of those 71 teams would have 13 members, so we're not at full membership of those teams. So adult teams would be made up maybe of 7 individuals. So the professions that would be represented in the teams, consultant psychiatrist, NCHD, nursing, social work, OT, speech and language, psychology, social care worker. Am I missing?
Speech and language,
Occupational
therapy.
So you've a broad range of the therapy, as well as the medical, as well as nursing.
All right. So I'm just reading the report, do you know what I mean, here in front of me, and it says that the HSE quarterly performance report for January to March 2019 show all but 2 of the 9 community health CHOs falling below the target of 100% response rate to acute CAMHS referrals, with the service in Connacht also particularly below target 54.6 and in 29.6 for the CHOs covering the region. Does that particularly relate to the teams? What's my reading of that, or can you explain that commentary to me?
So you may recall that Minister Daly had sought to explain an emergency response. So when a young person is referred to CAMHS, if it's deemed as an emergency by the team, then we have a target of, I think it's within 24 hours that young person, or 72 hours that young person will be seen. So it arose as a result of a particular situation a number of years ago. The figures that you have there are ones that we will have put in, and so I have some concerns about the validity of those figures, to be honest with you, and I need to come back to the Chair. We've checked out on those, so we would expect that 100% of young people would be seen in emergency within that period of time.
Yeah, because very clearly here what it's saying to me is that geography is playing a part in all of this. And Connacht Ulster, if you're a child in emergency in Connacht Ulster, you don't get the same response or the same support that if you're in another part of the country. Is that a fair reading of it there, Jim?
It's a fair reading, and unfortunately it doesn't do justice to the people that are working, particularly in Galway, as you will know.
Yes.
And that's why I have a difficulty with the actual veracity of the figures, and I have challenged them the last number of days. So I need to come back to everybody on that, because it may be a little bit about how people have defined what an emergency is. So, for example, a person may be referred in an emergency, but when they're assessed by the team, it may not be regarded as being an emergency. It may be something else that's going on.
So I suppose then it's going to bring me back to the first question I asked again, about the 60% of the teams are fully and adequately staffed out completely.
Yeah.
That's 13 on 60% of the teams. So how many of those teams then are fully staffed out in the Connacht Ulster region?
Offhand, I'm not sure. I can get that information.
Would you mind sending us that in? Because that's important. In relation to the disability side of the mental health part as well, how is the integration going on, particularly for young people who present with CAMS, ADHD, Asperger's? I know that in Galway, and you probably are aware of this, where we had 200 people, young people, who were on the CAMS waiting list. But then there was a complete overhaul 12 months ago, and now there's a disability element, and they were put over to the other side. Like, have we got through all those 200 people that were moved from CAMS to the disability? Because really they were put under CAMS to begin with. What's the update on that?
I may say, Professor Doody may say, one of the challenges we have, CAMS is a secondary care mental health service for people, young people with a moderate to severe mental illness, as distinct from somebody who might have a disability and a mild mental illness. So the reason why we have to be very clear about that is that that's how we manage our services. So primary care services are there to deliver for people who have mild mental health issues and may have some disability issues. The moderate to severe are our CAMS teams. So that's just the way in which we try to differentiate. Why do we differentiate? It's because, as Professor Doody said earlier, about 2% of the population, young population, will require CAMS at any stage. We have to ensure that the teams that we have are available and able to meet the demand from that 2%, not for those who may have a mental difficulty but who may not meet the criteria for CAMS. That's why we have invested in other interventions like primary care psychology. It's one of the reasons why we obviously invest in Jigsaw and many other NGOs, in order to make sure that there is a primary care response and a more universal response, as well as those then who may need to be seen in a secondary care situation. Brendan, would you want to comment a bit more on the MHID bit? Or?
Yeah, and just come back to the teams as well and the staffing. The Vision for Change recommended a total of 11 clinicians plus 2 support admin staff for a population of 50,000. Now, in Ireland, that's 12,500 young people, because 25% are on average under the age of 18. I think the teams have increased, as Jim said, now to 71. The teams, although they would be not up to the full 11 staff members, they would have representations of all the disciplines, because Vision for Change recommended, for example, 2 psychology posts, 2 nursing posts, 2 social work posts. So what we find is that the teams, if you look, I think the average, I think on the teams, is more, between 6 or 8. I don't have the exact figure, but you will find that most teams would have close to the full multidisciplinary complement, but not necessarily to the level that Vision recommended. So the priority had been to fill that. Now, not all teams will have the full multidisciplinary complement, but I think that can often that there's 2. There's one has a team got a full multidisciplinary complement, and it would have that at about 70% of recommended for Vision. But then Vision then would have 2 psychologists, 2 nursing, etc., 2 social work, and that was what was recommended. So that's with regard. So I think then when you look at the staffing says that if you look at Vision for Change, you first of all see that actually it's more than nearly 80% the number of teams that Vision which would recommend, which is 90, but that the teams that are there in place would only have about 70% of the recommended staffing as per Vision. So that then brings the figure down to under 60%.
All right.
If that makes sense. So that is the staffing.
But with the height of respect, but a team can only function if everybody is part of the team. That's the definition of a team.
Yes.
That everybody is there and they all have a function. So surely they all have a role to play within it. So there's different levels of sign-off. So how can you have sign-off at different levels if you don't have a full complement on the team?
Well, the point here is that, and again, I suppose it's there may be different, as I said, the way teams have been failed is that as I said, the first priority is to, as you said, is to provide a full multidisciplinary complement. Now, clearly, given it is as Vision recommended, that multidisciplinary complement means that certain key disciplines need to have 2 members present on the team. In some teams they are in place, but in many teams they're not, and you just have one of that particular discipline. So it's not at a level, obviously, as recommended for Vision, but at least the team does have that full multidisciplinary, as you say, complement, such to provide that multidisciplinary response, because the needs of children and families coming to specialist mental health services are quite complex, and you do need access to that full multidisciplinary skill mix so you can provide an appropriate package of intervention and care. So, but again, we're not, as I said, the resourcing of services is not as a level that Vision would have recommended.
So, with the question you're asking about sign-off, so if you have a team, not all young people who will go on, who will be accepted for CAMHS will require speech and language, for example. Not everybody may. But as part of an overall multidisciplinary assessment, when they're being assessed initially, the question is, what element of our service will they need? So in that situation, ideally you will need your psychology and everybody else. There are occasions when, if we don't have a speech and language, we may be able to buy that in on an agency basis, or we may be able to go to primary care and say we need assistance on speech and language. So our teams develop from consultant to NCHD to nursing and then AHPs on the basis that you need a consultant to start the team, because the consultant is the team leader. So we are obviously very conscious of the need to have a full MDT approach, because that's what CAMHS does best. But there are occasions when that's not in place.
On the same report then as well, Jim, it says, while CAMHS have made progress since 2017 in reducing the number of young people waiting more than 12 months for an appointment, increasing demand for the service has led to a combined national waiting list, and this is up to March, of 2,738 young people as of March of this year. This represents both a year-on-year increase and a higher figure than had been anticipated by the HSE, indicating a service under continuous strain. That's it in the round. So, when you talk about buying in the support to the services to ensure, we talk emergency, like this, anything that's going into CAMHS is acute, it is an emergency. Why aren't we buying it in? Because would we not have used some of the new funds to actually have bought in the support services on whatever part we were under pressure from the team?
So, a number of things there. One, the demand for services is continuing to increase. And if you go back a number of years, we have gone from 40 teams to 70 teams over the last number of years. So we're attempting to try and increase the capacity as well as trying to meet the demand. Part of the challenge there is about the recruitment issue that we mentioned earlier. And so in order to get a team, you do need a consultant child psychiatrist at the beginning, because, for example, medication and all sorts of other reasons, you need a medical doctor initially. So your AHPs work with and have a very significant, important role to play. But in CAMHS, when you say that all are emergency, there are some that are more urgent than others, and we have to try and respond to those initially.
Final question to you, Jim, before I go to Jigsaw. How many of the teams then don't have a consultant child psychologist?
Consultant child psychiatrist.
Psychiatrist,
so
sorry.
Each of those teams, either through permanent placement, locums, or agency, all of those. I think we have all of those teams.
So 71 teams. 71 teams have a head lead on them.
So what I'll do is, just so as I don't mislead anybody, I will come back to you with details. But I mean, we very rarely, there may be occasions if somebody is sick or somebody has left and we're in the process of recruiting, where we might ask a consultant from outside that catchment area to provide, cover. But I will come back with specifics. But that's our general principle.
Just to say about, can I just make a comment about the waiting lists? As you can see, the waiting lists are not evenly distributed around the country, and that the areas that have, in other words, have the resource that's available and the most consistent resource available are those which will have the lowest waiting lists. So I think that, again, as you would expect, when the teams are available and consultants are available, and I think this is the key, having the multidisciplinary team in place on a consistent basis, consistent availability, because other issues can happen, obviously, where there's teams where there's a lot of turnover of personnel or agency or locums in positions on a sustained basis. So there may be a number of factors. So when you're looking at waiting lists, you need to look at, in general, it is a resource issue. And then secondly, there may be specific issues relating to a particular area that can explain the kind of variance in waiting time and waiting lists. Again, to echo what Jim said, that when a referral comes in, a referral is triaged. So a decision is made as to what response or the timeliness of the response. So as you can see from the reports, that actually 50% of referrals are seen within 4 weeks. And 75% are seen within the 12-week framework. So, as you can see, the issue is that often that the less urgent cases are the ones that are left on waiting lists, because obviously they are being replaced obviously with new, more urgent referrals which are kind of superseding them. As I said, I can speak for the service and in our service and how this happens. It doesn't say that young people who are on waiting lists do not have an identified need and require a response. But it's that services, if you have less and less resources, it will be taken up by the more urgent referrals, and that will mean that those with a less acute need, that their needs are pushed back and not as met in a timely manner as they should be.
Just my last question is for Jigsaw, if you don't mind, Chair. It's to do with your new projects. All right. Has Tipperary started?
No.
All right.
The plan is to begin Tipperary by the end of Q1 next year. So
but if you don't mind me asking, have we not extended that and extended that and extended that? Because we're talking about Tipperary for at least the last 18 months.
No, there was confirmation earlier this year that Tipperary was to be one of the new services, and the agreement with the HSE that will be by the end of the first quarter next year.
All right.
That we would look to focus on Wicklow, the service there first. But one of the big issues in having a service now that the resources are there is about finding a premises. And that's a big issue that we're facing across the country and in a number of areas. It's finding a premises that's with an adequate rent, that's going to be at the appropriate size, and so on.
And have the HSE no buildings that we could, Jim? We've no buildings.
So, you see, Jigsaw as a type of service is a youth-friendly type service. So a lot of our buildings, we want to stay away from our buildings, to be honest. Like, if you look at what's going on in Essex Street, one of the Dublin City Centre one, that was the Dublin City Council premises, which is bang in the heart of Temple Bar. It's where it's all going on. We don't have services there, and frankly, it's the sign of, well, I wouldn't go there because it's a HSE, whereas when it's Jigsaw, and it has a different connotation. So we have looked at in both Tipperary and in Wicklow, but there aren't appropriate services there, or there aren't appropriate buildings. Yeah.
Thank you for the responses to Deputy Rabbitte's questions. I move to Deputy Chambers, please.
Yeah, thank you very much, Chair.
I've read your opening statement, and I understand the point that mental health funding has increased, but there are very few cases that come into my office that are deeply upsetting and stay with you. And there's been a couple of mental health cases from young people that have really really shone a light in terms of the services or the lack thereof in the community. The west of Ireland in particular, I'm in County Mayo, and we don't really have youth mental health services. There are voluntary organisations, Pieta House, some other charity organisations trying to bridge those gaps and provide some level of service. But I think the biggest issue is first and foremost, if you're sick after 5 p.m, the only place you can go is the emergency department. And if you're having a mental health issue, if you're suffering from severe depression or anxiety and you're having an episode and you're having a difficult time, that's the last place you want to go, is the emergency department, because as most people will know, most EDs in the country are overcrowded and manic and chaotic. And that's the last environment any young person should be put into, but that's all that's there. I had a particular young girl into my office who was 21 years of age at the time when she spent 3 weeks in the adult mental health unit in Castlebar Hospital. She was there involuntarily. There were no activities and no structure in the day. There were a list of activities on the wall, so if the unit were to be inspected, it looked as though there were things happening every day. But none of those activities ever took place, except for a 1-hour music lesson in the week and Mass on Sunday. That's all that was available. She wasn't able to leave that facility. There's a small little courtyard, a little garden. It's no bigger than this room. It's kind of a square shape where you can walk around. It's a glorified smoking area, really. And that's all that she had for those 3 weeks that she was there. The only reason that she got out of there is because her parents could afford to put her into private care. And she fundamentally believed the only reason that she's better now and doing well is because she got private mental health care in St. Pat's. And she felt if she was left in Castlebar, she'd be in a very different space today. And thankfully, she's doing well and in college. And she's determined now to help others that are in that situation and can't get out. She spoke about a culture of sleeping tablets, medication, no psychological services. If the first sleeping tablet didn't work, you were given a second one 2 hours later. People left sobbing, crying in the middle of the night. Nobody there to show any compassion, to check on them. People of all ages, all illnesses in the same small facility with no way out. I mean, you know, in a first world wealthy country, that is just, it's disgusting and it's unacceptable. This is a HSE facility. And it wasn't too long before, a number of months back, where I was told everything was fine in that facility. Services were good, plenty of staff, plenty of resources, no problems. She spoke about bedclothes not being changed, elderly patients being left, the place having a smell, being unhygienic. Like, it's unacceptable. And I'm sure that that facility is replicated right across the country. I have no doubt that, I mean, Castlebar isn't an outlier. It's a fine hospital and provides great services. And Jim, you've pointed out, it's not the fault of staff. They can only work with what they have. And, you know, I've gotten parliamentary questions back very recently around the vacancies. It actually goes to 2 pages, the number of vacancies within the mental health unit in that one hospital. One of the vacancies for a basic grade psychologist has been open since 2015, and there's no date as to when that post will be filled. There are several vacancies in CAMS, most of those 6 months, a year, longer, again with no date for those posts to be filled. So clearly the staff that are working there are doing, each staff member must be doing the job of 2 and 3. You know, I can't see how they're not. But how can there be no psychological services within a mental health unit that's treating people that have been involuntarily committed to that unit for a number of weeks? How is that even possible? You know, no gym facilities, no structure, no place to exercise. I mean, any one of us, if we were in those facilities for 3 days, never mind 3 weeks, would be climbing the walls. I mean, she spoke about not being able to sleep at night because of the noise, people wide awake at night because there was nowhere to burn off energy during the day. So of course you're wide awake in the bed at night. And, you know, you can imagine the noises in a facility of that nature where people are stressed and upset and suffering from severe mental health episodes. I don't think I'll ever forget the day that lady called into my office, and I'm still in contact with her, and she's one of the lucky ones. And, she actually sent me on a poem that she wrote. I won't go through it all today, but, she's an exceptionally talented young person. But she went on then to speak about her experience in St. Pat's, the private hospital that she went to, and the wraparound care that she received. Basic things that every service user, every resident had to get up for breakfast every morning. That was part of being there. So there was structure. Your bedclothes were changed. You were meant to have a shower. You had activities during the day, whether it was yoga or dance or art, something, to positivity during the day, and that she felt that she was being cared for and that she had the opportunity to get better. And what really upsets her now is that she feels there are people that are being readmitted all of the time. The same people going back in to these units because they have no opportunity to get better. So when are we going to change how we deal with this? And if you rob a child, a young person at that age, of the opportunity to get better, what hope have they in later life? Very little. And that's not all on your shoulders, Mr. Ryan. You're the HSE representative today, and it's an opportunity for us to question and put those things across. But until we change how we do things, and perhaps the HSE needs to look to these private facilities and say, well, how are you doing it? And of course it's going to be expensive. But the proportion of our health budget that goes to mental health is too small, far too small. We all know this. So telling us that the budget has increased, since 2012 to over 200 million, that's buttons. It's not working. It's not enough. And I'm sure Jigsaw will agree. I mean, you're on the coalface dealing with it every day. So, a nice office in Temple Bar is great, and it caters for some young people, and it's great that you're in the community. But right now we're failing young people in this country, and we're committing them to a lifelong mental health issues where they won't be able to recover. And on a very basic level, if we could have a bit of honesty from the HSE to our government, here are the vacant posts, here's why we can't fill them, we need more funding for mental health services. This has to be a priority. This is far more important than the next motorway or the Lewis extension or the Dart extension. It's far more important. The most basic thing a country can do for its citizens is to make sure they're healthy. And isn't your health your wealth? Isn't that what they say? If you don't have your health, you have nothing. So our health service has to be the top priority. And mental health service right now is the poor relation. And we need a bit more honesty rather than saying things are great and we've been progressing in the right direction. They're not good. They're far from it. And I think government need to hear that from those on the front line, because hearing it from the politicians, it's a bit like it just slides off. It doesn't have the same weight. So I don't know what you can say to Hannah, because she's not the first individual that I've had in those circumstances, but she has certainly left a mark on me. And I think, I do think that by her having the bravery to come out and tell her story, that she will help others. And she's a very determined young woman to make sure that the services improve.
Would anybody like to make any comments on those points?
So maybe if it's okay.
Sure.
I also get lots of feedback from patients who contact my office telling me of their experiences in some of our services. The context in some respects, and I'll be brief, but in 1960 there were 20,000 people in psychiatric hospitals in this country. We now have 1,000 acute inpatient beds. We are one of the lower uses of beds across Europe. So we've changed the model of care from institutional care to community care. That is challenging in that we have to ensure that our community services are in place to ensure that the beds that we do have are for those who need them the most. The experience that young woman has had, I can't condone the way that her experience had, and I understand it. I have responsibility for Central Mental Hospital. We have people on waiting lists to come into the hospital from prisons. So I understand on a day-to-day basis, this morning even, of issues like that. What we have tried to do, for example, if you in Galway last week, we opened a new 50-bedded unit, which is a state-of-the-art unit, which is open for 12 months and formally opened last week. We've opened units in Drogheda, in Cork. We've renovated Limerick, Sligo. We're trying to change the way in which mental health services are delivered, but it can take a period. It is taking longer than any of us would hope. The issue in relation to budget and staffing, I agree. I'm head of operations. Obviously, I would prefer that we have more resources, and the submissions we make are based on the need. particularly as outlined in Vision for Change as our policy document. But we also have to recognise our ability to actually staff the units that we have. And that is a constant issue that we have about trying to recruit and retain our psychiatric and mental health services for our services. In relation to what to do during the day, one of the things that when you come out of hospital, we have, particularly in Mayo actually, we have a very strong recovery college based in Castlebar, which is where service users have been involved in setting up recovery colleges, including RAP and other programs that they've implemented. That is because we have a relatively small number of inpatient beds and we want people to be in there for the least amount of time possible, so that when they do come out, that actually there is something for them to plug into immediately. We have employed peer support workers, service user leads. They're all people who have a lived experience of mental illness and who are changing the way in which we're delivering services. So I'm not going to sit here and say that the experience the person has had is anything other than unsatisfactory. And I'm not just saying that. I believe that personally and professionally. But I have to try and work with what we have and also try and change things. The budget issue that I'm saying about the increase in funding, I acknowledge that the budget increase is trying to go from a low base. We have about 6.7% of the overall health budget in mental health. Other countries would have 8 and 9%. So that's an issue that's above my pay grade, and it's points we have made time and time again. So they're just some of the points, Chair. I acknowledge and always disappointed to hear when people have had bad experiences of our services, particularly for the people, and I know the unit in Castlebar, I've been up there many times. And I often ask myself, if I was in that situation, what would I want? And that's what we're trying to achieve, a much better service, so that when people are in there for the shortest time period possible, that it's still helping them when they come out, that they have something else to do. For example, today we have 30 specialist rehabilitation unit beds, which we have purchased outside of the HSE in 2 services here in Dublin, which Minister Daly is launching as we speak, where we recognise the people who are long-term in inpatient units who have become institutionalised and are unable to then come out and have, I suppose, get into more meaningful life. We expect that within 12 or 18 months that will make a significant impact on we have 30 beds in those 2 areas. That will make a difference, and we would hope that we would extend that across the country over the coming years. So we are making efforts, but at the moment there are still deficits.
Thank you very much. I now call on Deputy Sherlock, please.
Thank you, Chairman. And I thank you for coming before us today, and I don't doubt that you are seeking to make a genuine effort to tackle the issues. And, you know, these are sensitive issues, and I think one of the common themes that's emerging here today, Chair, is the issue of resources, quite frankly. I don't doubt that, and you know, I acknowledge former Minister Kathleen Lynch's role in seeking to progress matters, particularly in the mental health space, and the challenges that she faced, particularly in respect of getting more of a slice of the health budget assigned to, you know, mental health. So I understand the constraints in that regard. Can I talk specifically about Cork? Can I just ask, how many inpatient beds are there in Cork at present?
So the Aisling unit in Cork has capacity. They're refurbishing the unit at the moment, and the reason for that is that they're putting in a high dependency area. Yeah. So that unit was built for a capacity of 20. One of those rooms was a double room, and there wasn't I know, before my time, and there wasn't a high dependency area, which meant that if a young person was to be admitted to the unit who needed high dependency area, they were unable to admit. So as a result, they have used, I think it's 2 of the rooms in order to be able to create a space which is suitable for a young person who needs time out and who may need particular treatment for a period. So 16 will be the operational numbers.
So will be the operational.
Yeah.
How many just at present?
As we speak, I think 12, I think is the number.
12. Yeah. Are they at capacity every night of the week?
So that's That's a difficult question because it's a clinical question. It's not one, and I'm not trying to avoid the question.
I know.
So, for example, if a young person is part of their treatment programme, they may be out. It may be better if Brendan, who manages a unit at the moment, the Lindara one. So, to answer your question, because Minister Lynch has visited Aisling and was looking at how many young people were there versus the number that they said were there. So, for example, there are some young people who may be out on leave, and there may be some people who, as part of their care plan, are going back home, and so they may not be in the unit that particular day. But
my motivation here, Chair,
Sure.
is whether there's full occupancy or not, it's trying to understand what the culture is that exists within the acute inpatient facilities, okay? And trying to have some degree of knowledge and transparency around the decision-making process whereby a person finds themselves in one of these units, and whether or not, because of the culture or the decision-making process, that there are, from time to time, situations whereby some of those beds are left vacant for prolonged periods of time when there is clear evidence of a demand for those beds.
Okay.
And I don't have sight of that. You may not be able to answer that question today. That's something I'd be happy to revisit with the HSE and yourself, Jim, at a future meeting separately. Sure. But if there is such a demand for services out there, and if it is the case that there are empty beds, then there's a disparity there, I think, that needs to be addressed. And that's really where I'm coming from when I ask that question.
Okay. I may ask Professor Doody to speak about one thing, but just for the benefit of the members, every Monday morning there is a telecall chaired by a member of my staff with the 4 inpatient units, looking at the number of referrals that have been made, their current occupancy, and any if there are beds available. So we look at what referrals have been made across the 4 units. We then talk to the paediatric hospitals, so that if they have young people who are in the paediatric hospital who require admission. So every Monday morning there's a list prepared about how many are in. I know every Monday, I know every day of the week, but I know every Monday in particular how many young people are in, how many vacancies there may be, and what young people are going to be admitted during that week. Brendan, you may talk about the experience of running a particular unit.
Right. And when we're looking at, I can speak, the unit in Cork, and I think it's important to bear in mind, was a refurbished building. It was not a bespoke build. We had the advantage in Lindara of having a bespoke build, and so we were able on a greenfield site. And we configured it very much based on, obviously, best evidence and also experience from units in the elsewhere, and particularly in the United Kingdom and Northern Ireland. And we configured it in a way that our beds are 2 11-bedded units plus a 2-bed kind of high dependency. Our capacity to respond to admissions depends on the acuity, kind of the case mix. It also depends on our availability of our high dependency unit. And I know for a period last year when it was not available to us, it severely reduced our capacity. Remember, a CAMS unit, we have to manage young people with a very diverse range of presentations and ages. So admissions right down to the age of 12 with severe anxiety disorders, depressive disorders. We have a significant proportion of our admissions to inpatient facilities have quite severe eating disorders. And then trying to manage that in that open facility, a young person who may be, as a result of their mental health, in a very distressed and agitated presentation, how you provide a safe environment for not only managing and treating that young person, but also being mindful of the other young people on the ward as well, and providing obviously a safe and therapeutic environment. That is much easier to do, obviously, in a unit where you have, obviously, the facilities, for example, access to a kind of high dependency suite, where that young person can be managed for a period of time until such time they're ready to join the kind of the open ward.
So Professor, and I don't want to kind of extrapolate too much from what you're saying or kind of put words in your mouth, but you spoke about Lindara versus the Cork facility, Aisling. Aisling is a refurbished facility.
That's correct.
would that come up to the mark in terms of a fit for purpose or appropriate setting post refurbishment for the type of structures that you're just talking about there?
Well, what you're looking at is that, again, it depends on, obviously, the acuity of the cases you can admit at a time. So, in other words, if you're looking at the full range of young people who can be admitted, when we get a referral to Lindara, we have to make a determination as, are we in a position to be able to provide safe therapeutic care to this young person? Clearly, the physical, obviously, that is doing, you're looking at the resources, staffing resources and the skills of the staff, but you're also looking at the physical environment is also going to be a major factor that you have to bring into consideration. So when you're looking at that, and then you're looking at the acuity of the mix of the other cases on the ward. So and again, this is seen across all units, that even though your capacity on a CAMS unit may be, let's say, 11 beds, 12 beds, that your ability to admit a young person at any one point in time will depend on the acuity, because again, you may have young people who may require additional nursing, who may be on a one-to-one nursing. So you have a lot of factors that you have to consider when you're looking at being able to admit a young person. And again, it's important that that young person can be managed safely in that environment.
Okay, because my time is brief. So just go, I'll come back to you on the Cork facility at a future date, because I think there are further questions to be asked of that facility, and in seeking to maybe shed light and understand better the dynamics that inform the running of that facility, for which there have been legitimate questions in the past in relation to the culture that exists there. Okay, just in relation, I have 130 individuals waiting more than 18 months for CAMS assessments in my neck of the woods. Okay, and if I'm reading, again, the interventions correctly without putting words in anybody's mouth, the word resources is the key word here that is preventing children and families in my area from receiving, proper assessments. Okay, and I understand that you have a multidisciplinary team. I understand that there are constraints in relation to recruitment and so on. Has the HSE looked at the multidisciplinary team model in respect of reducing the numbers on the waiting lists in such a way as to redeploy resources from other areas, or from the point of view of outside recruitment on short-term contracts, or ensuring that or looking at the multidisciplinary teams in a way that ensures that maybe with proper supervision, it might not necessarily have to be a psychiatrist that would make the initial assessment, and it could be somebody else under the supervision of a psychiatrist. The bottom line here is, I have families, they need to get the assessments, and they need to, because if we're talking about staving off problems down the line that Deputy Chambers has referred to, the intervention at the most earliest stage, that's self-evident, and I'm not a physician, can stem a lot of problems down the line. So I just, if there were more imaginative solutions to ensuring that we can get the list down in spite of the capacity and resource constraints, is that being looked at present?
So the short answer is yes, and particularly in Cork, as a result of 3 or 4 years of a number of waiting list initiatives, which we've looked at. Obviously, staffing is an issue. We've looked at, if a consultant is not there, can a consultant cover from another area? We've looked at bringing in consultants on agency, on locum. The model that we have, where a young person is seen is triaged, as Professor Dooley said earlier. But each team will need to have...
And I do apologise for cutting across.
No, that's okay.
Like what Professor Doody is saying, and if I understand him correctly, is that 50% are seen within 4 weeks. Like, I've got 130 waiting 18 months. That's based on a PQ now, so that's your own answer back to me.
Absolutely.
Like, there's a big gap there,
Yeah, and so what tends to happen is that the young person with the greatest need is seen earliest, and as Brendan said, that sometimes means that people who are not the most urgent are waiting longest. I think all of the time that I spent the most time from Cork at home by trying to make sure that we address those waiting lists. I'm down there again on Friday. We have another way of trying to look at this. There are some things that we have to address with the current staff about trying to do things differently, because if you don't have a child psychiatrist, it can impact on your ability to do the initial assessment.
Okay. And can I ask then, what is best international practice vis-à-vis the multidisciplinary teams? Is it a flat structure, or is it a very hierarchical structure where that psychiatrist is the head honcho, if you will?
So,
is that best international practice, or does it differ in other countries?
Clearly, the teams there needs to be a clinical lead. Okay. So even if you look abroad, there's always a clinical lead, and there's a lead on the team. In a way, the way the consultant contract is actually configured, clearly is that that role is defined as being that of the consultant, which is also it's also, as you will see, that's also contained in Vision for Change. That the clinical leadership of the team is provided by the consultant psychiatrist. So I suppose that is the model, and that's the model in Vision, and also reflected in the consultant contract. That lead clinical role is that of the consultant.
Okay, thanks. Chair, I'll follow up with.
That's okay.
that's fine. Thank you.
I'll follow up with Jim maybe, and we might have a meeting in Cork in respect to services
Friday.
in Cork.
Absolutely. Thanks very much.
Yeah. Thanks, Chairman.
Now, Colin Deputy Mitchell, and followed by Deputy Alison Buckley.
Thanks, Sherlock. Thanks for your opening statements. If I can just touch back on what Deputy Sherlock was talking about, so regarding waiting lists. So, what is the average waiting time for a young person to access services?
So, it may be. I don't have that with me. I can tell you across every one of the 70 teams what the waiting list is, but I don't have an average. If it's okay to the chair,
would it be possible to forward that? So you could forward it on the average waiting time and probably where the longest as well. I'll do that. I appreciate that. You mentioned in your opening statement about eWell. So I'm wondering, would you be able to tell us a bit more about the eWell service?
So. It's a 6-week CBT therapy program, which our primary care psychology side are looking at. I suppose it's an add-on to what our current face-to-face are. So, for example, if a young person or an adult is on a waiting list, it may be possible in advance of that, and I know Jigsaw are working on some of that in their own service, where we can offer mental health initiatives, or in other words, eWell or eCBT. We're doing that through our own services, but we're also doing it through Turn to Me, Belong to Me. There's a number of different external organisations that we're piloting at the moment to see the take-up. This is going to take a bit of time because not everybody is comfortable with doing that online. But our experience of young people is that they're accessing their information much more online now than certainly than my generation would have. And so we have to address that. So that if social media is seen as being one of the difficulties that we face, it may also be a solution to some of the issues that we face. And Minister Daly has, as you know, has been leading in I suppose pushing that particular agenda. So the eWell, I'll send you specific information on it, but that's the general gist of it.
And when do we expect it to be rolled out? Have we got a time frame?
So we're looking at early 2020 because we have to go through a piloting at the moment. All of the concerns that somebody will have on a one-to-one with a counsellor have to be built into anything that's done online. But
do you think it's replicating Jigsaw's, or
So I don't think it's replicating, but you're correct that we have to be careful about funding a whole variety of different online initiatives. But I think our experience is that young people access it in a way in which we've no control anyway. Yeah. They will go online and they'll look at Spun Out, or they'll look at Turn to Me, or they'll look at something else, and it may be American, it could be Australian, it could be any variety of different options. So we're trying to ensure that what we're delivering is evidence-based, and it's also backed up with proper clinical governance.
Okay, that's great.
Presumably it's a unique product.
Yeah.
It's
in
unique.
Ireland.
It is, but I suppose the way the world is now, you find that people are accessing online counselling from any variety of different sources. So it's almost like it's a very fractured market almost at this stage. For example, we're also working with VideoDoc, who are providing online counselling through VideoDoc, because they're actually doing that themselves anyway. So if you look at Aviva or VHI, they're all looking at this because it's a means of trying to deliver services to people in their own home at a time that suits them. without necessarily being on a waiting list.
Can I just ask Jigsaw just two questions? In your opening statement, you talk about supports needed to upskill those who work directly with children. And there was one bit that stuck out with me when you said that only 1% of primary school teachers felt that they were adequately trained. So I'm wondering, what sort of supports do we need, and what upskilling do these teachers need, to be able to support children?
We've been working with teachers for a number of years, particularly because we've connected with them through schools. They would ring up the Jigsaw service and say, I've got a pupil here, I've got a concern. And we realised that there's several different things. The teachers themselves would say that they were trained to teach a subject, but the reality is that they're teaching the whole person. So they're teaching the young person, and their young person's ability to learn, to participate in class is obviously hugely influenced by their well-being and their mental health. So what we've been doing with teachers and working with the teachers' education centres is upskilling the teachers in terms of awareness around mental health. And we've done a lot of work around the concept of one good teacher. So how does the teacher not sort of freeze when they hear a young person's concerns, and to know about the connections to services in the community. And then we've built skills as well. So what we've done is we've worked with the National Education Psychology Service, local primary care. We particularly worked in Meath, and then we're spreading that out now into a model called One Good School, where we're looking to support teachers, support the parents, support the young people, because for a long time we've had a series of smaller initiatives. So we've had peer education with young people that can participate in, and they then are trained to talk about mental health, and they deliver that to their peers, their pupils in the school. We've had parents who've been educated in terms of how they can support young people. So we've looked at this in a much more holistic way. Okay,
very good. Can I just ask you, in general, what's the outcomes for a young person who goes to Jigsaw?
Do you want to take that, Sarah?
Yeah. So I suppose our evidence will tell us, a lot of young people who come to us. Part of what we do is we evaluate outcomes for each individual in terms of looking at their levels of distress when they come to Jigsaw, when they first come through our door, and also at the end of their intervention with us. And our outcomes are really positive in showing that our early intervention service really does work. So a large majority of the young people coming through the door will, when they're leaving the Jigsaw service, will have much decreased level of psychological distress. I suppose the other thing that we look to do is, I suppose, help them build their capacity to encounter, to support them when they encounter challenges again in the future. Because I suppose Jigsaw doesn't set out to eradicate mental health difficulties. That's part of the human condition, and challenges young people will encounter them again, whether that's in relationships or schools or transitions. So part of the intervention with Jigsaw is, I suppose, to help them, when they walk out the door, that they're taking with them some tools and some tips that help them when a challenge might present itself again. And last week we heard from a panel of service users who came to give us some feedback about their experience, and one of them in particular talked about a folder that she had built up with the clinician that she worked with, and having some hints and tips, and knowing her own triggers, so knowing when maybe things are feeling a bit more challenging and when her mental health is maybe slipping that little bit, and being able to go back and remember the things that she worked on in the sessions with that clinician. So I suppose the idea is that they're bringing something away with them for inevitably in all of our lives something will come up again and present itself. But I suppose the important thing for us is that the data, not just for Jigsaw but internationally, would say that the outcomes in terms of an early intervention service, really does work in alleviating that distress.
Can I just touch on that about community services and early intervention? In my own area in Coolock, in the past 2 weeks, we've had 2 young lads who committed suicide, and the community is on its knees. And knowing the lads, knowing their families, it's so difficult when you're in a church and you hear, the cries, and particularly young men who are carrying their friends out on their shoulders. So I'm just wondering, when in an area where there's a spike like that, does resources be put in, to the area that these young men and young women can actually go and talk, about it, and even for parents who are concerned, Is there, is there an avenue for that to be opened up in an area when there's such a spike in suicide?
Yes, as you may be aware, we have a service level agreement with Pieta House, and they provide services in local areas. We also have suicide resource officers in each of our areas, and by and large, when an issue of a spike happens in an area, they're the people who will know that straight away and will put services in place. It may be afterwards, if you let me know, we can look at that particular.
That. Yeah, thank you.
Okay.
Thank you very much, Deputy Mitchell. Deputy Alice, please.
I'd like to thank both of you for your presentations. And I come from, I represent Dublin North West, which is an area with a very high suicide rate, and people would know that. It takes in Ballymun and Finglas, and it's quite a serious issue. And I was curious about a number of things. One was the primary care centres that are being utilised across the country, and that's part of, obviously, that it ties into some of the youth and looking after the mental health issues and dealing with them. And that's a source where people can go to and engage with. And I know you're planning to put one in Finglas, on the Annunciation site, and I'm hoping that that's at a far more advanced stage now. But I think that's part of we badly need in the Finglas area, as you know. And you might be able to tell me what sort of mental health services there would be for young people in that, and what way that would work. Because you have Ballymun there with the primary care centre, which is working very well. And in Ballymun there now, I know from recent, and I had a few PQs in that psychiatric services for young people is 18 months to 2 years, which is really, to me, it's a hell of a long time. And I've been dealing with a case, and that's the answer that I've got from the HSE. I mean, we all know that to identify at an early stage is so important, and early interventions are so important. I'd like to know the type of engagements we have with schools. How does that work? Because the biggest problem is getting people into a place where we can identify who they are, what they are, and what the problem is. And is it the schools as your primary source, or is there any other way that we can look at it? Because within the schools we have serious issues in terms of online bullying, problems with cyberbullying. All these are leading to mental health issues in young people, and I'm just curious how much engagement now, and is that a primary engagement that you have? There's a third, according to the statistics you gave, a third of young people struggling with mental health issues on an ongoing basis. That is a massive high figure, and obviously we need to, we need to have the resources there. And it does worry me when I see Sherry McDade, the Mental Health Reform, coming out and saying the mental health services are very badly underfunded, and we all know, and I've heard what you've said, we all accept that they're badly underfunded. But I'm also very, very worried about the whole dual diagnosis issue, even with young kids in particular. It's an area that seems to cause problems, and it doesn't matter whether it's a young child or other that reports into a hospital or otherwise. The attitude seems to be, on occasions, when there's alcohol and drugs involved, and we are having a lot of young kids now smoking hash, smoking grass, and it's a big problem. So I'd just love to hear how we're dealing with that more and more in terms of the dual diagnosis. There's a lot of groups out there trying to help, and I mean Jigsaw is one of them, but it really worries me when I see the amount of private funding they get. So it shows you some of the big companies, I think Lidl and all that, are contributing, and fair play to them, and I think that's important. But it shows you the deficit in terms of funding from different departments and going to different resources to fund the likes of Jigsaw and other groups. And we do need funding on a regular basis and not have to be relying on private individuals or private companies or otherwise. I just think it's wrong. Education obviously is the big issue to get at people at an early stage, and tackle it at an early stage. I know there was in the past we've had issues where there was suicides amongst groups of young people, and it was like a ripple effect, several one after the other. And I remember in Dunsogly and Finglas there at one stage we had 3 and 4 suicides a number of years back, one after the other of young people. And I'm glad to hear you're saying that you focus in when that happens, you focus in with a team and try and get at those young people. But what way does that how do you outreach to those people? That's the issue. How do you identify those people and outreach to them, you know, and get them on board to try and stop something snowballing the way it did at one stage that I experienced. So maybe you could answer some of those, please.
Okay, so the primary care centres, the first, when you mentioned earlier on, so one of the things that so CAM services are delivered to primary care centres around the country. I suppose it's important though to say that what we're trying to do is we're actually trying to provide services for young people in locations that they will actually attend. Young men do not tend to, in particular, don't tend to go into HSE delivered services. We struggle with that. It's a phenomenon all over the world, but it's certainly a phenomenon in this country. I was a youth worker for 10 years in Tala, and you had a group called the non-joiners. So you had to have a very particular way of working with some young men in particular, because they didn't want to, they had significant difficulties attending GPs or anybody else. So that's one of the reasons why we partner with NGOs in order to be able to provide services in a way in which is more youth-friendly and more appropriate. So we don't want to be signing up outside the door saying HSE this or HSE that, because for some people that's a turn-off. And just in relation, I mean, I think we're a 94% funder of Jigsaw. So the other funding that they've had recently is for very specific purposes, but all of the counselling and the 13 sites are all funded by the HSE. And that's been a significant development over the last number of years. So the primary care centres, we're certainly going to have a secondary care and mental health service. The waiting list for primary care psychology is very large in some parts of the country, there's no question about it. One of the things we've done from a mental health point of view is that we've employed the guts of 100 or over 100 assistant psychologists across the 9 CHOs to try and address that particular issue. So we recognise the fact that if we have waiting lists at primary care, sometimes GPs and others will then refer to the next available source, which will tend to be CAMS. So we end up with young people on our waiting list who shouldn't be on it and who could be dealt with it at, let's say, a lower level. The dual diagnosis has been an issue, Deputy, for many years. It goes back to the drug task forces of the late 70s. In that is an addiction a mental illness, or where does it fit? So when you look at the drug task force policy and you look at the mental health policy, addiction is not seen as a mental illness. What we do have in this city is, as you know, Trinity Court, which deals with people who have both an addiction and a mental illness. But we're trying to get to a point where we have a no wrong door policy, which means that if somebody's looking for help, they're not turned away because they either A, have an addiction, or B, they have a mental illness. But we try to treat both. That is taken a lot longer than I thought it was going to happen. It's an international, still a similar issue, but in most other parts of the world, addiction and mental illness are treated the same. Some parts of the country that is the case here, but there is still a lot of work to integrate our services so that a person who asks for help isn't turned away because they don't meet a particular criteria. The support for groups, we fund hundreds of groups across the country, both on for early intervention, for suicide, and we actually have to try and manage that, because we have to make sure that the quality of the services that are being delivered are appropriate and the clinical governance behind are appropriate, which is one of the reasons why in some respects we need a smaller number of larger organisations, so that when an issue happens in the community, many people will come together, as is the Irish way, and they'll have a group who are very well meaning. But unfortunately in today's world you have to ensure that that's being done in an appropriate manner. You mentioned about schools, and we have, while our care is secondary care, some of the stuff that we have done is we've what's called the Mind Monster campaign, which is aimed at second level school students, and it's around 4 issues around examination stress, sleep, digital and feelings. That's a programme that we provide posters and people who go into schools in order to be able to support. And it's those 4 issues, because the feedback we've got from young people, similar to what Jigsaw will have had, is that they're the areas that cause the most stress. It's interesting, our inpatient units during the summer tend to have a less of a demand when young people are out of school. And the studies show that. So school is a stressor. I'm not saying it's stress for all of us, but if for some young people, that is a serious stress in their life. And just to finish on that, we also have a recharge programme for third level students, because you may have seen during the week where USI, and we fund interventions in USI where they're saying that exams, sleep and alcohol are the three key issues that we've addressed for our programme for third level. So we're conscious of the need to do it in school, but there are also young people who, as you know, are not in school, and so we have to try and have those young people connected as well. And the last thing is around suicide clusters. That has certainly been a feature of the past. We have to work with community groups to ensure that the way in which a young person's life is celebrated when there's a suicide is appropriate, so that it doesn't create, I suppose, a circus of issues which some other young people buy into. So we've certainly spent, we've tried to analyse that and ensure that the support that's put in is done through Pieta and done in an evidence way, but it's not creating a drama, which sometimes can happen. And as you know, priests who are officiating it, they have been trying to do that, so that there isn't another drama for young people to buy into. Thank you, Chair.
Thank you, Mr. Deputy Ellis. Sorry,
could I just,
Dr. Duffy.
You mentioned there, Deputy, in terms of the funding for Jigsaw, as Jim Ryan has clearly said, the HSE are hugely supportive of the Jigsaw services. From our model from the very beginning, we've worked with, I suppose, philanthropy and private fundraising, particularly around innovation, and we're innovating, I suppose, around schools, around online, the research that we do and some of the work that we do in the community. We use that funds really to develop a proof of concept, because some of the ideas, that the ways that we might work with young people, the way that we might provide information, there isn't maybe an evidence base for that. So we develop that over time, and then what we do is, and that's how Jigsaw had developed in the first place. So I suppose that's what where we would see is a really good match between the community side, the corporate side coming together, and that there is real benefit from it in terms of managing that, and they complement each other in terms of managing the work with it.
Yeah. Now, there was a few things there that I just felt you mentioned about secondary schools. It's primary schools as well that is a big problem. And how do we identify people, particularly young people? Where are they going to go? Where's the first port of call? And you said yourself there they don't want to go into a HSE building or something like that. But we have to have places, and we have to be in the schools at an early age, whether it's in primary or in secondary. And we have to have a continuous programme within those schools, and it laid out on an ongoing basis that you have. I wouldn't be the best at describing it, but what I would say is that you would have to consistently have for each school a particular day or a particular week, or that you would go there and try and identify the problems and see and engage with the teachers, the principals and the pupils to find out what level we're at in terms of the problem. And the other thing is, we used to have probation people going around when kids weren't in schools. those are the people that are missing out of the equation in a lot of places. And we've done away with these probation officers. You don't hear of them anymore. Well, I certainly don't hear of them anymore. There used to be a big thing, people would call, and if someone was missing out of school, and you don't hear much of it anymore. But it helps in identifying whether those children have problems and they can be engaged into services. And I think that's something we need to look more and more at. The other issue I mentioned earlier was the online bullying and the cyber bullying, which is now a major thing. And the only place you're going to, get at people that's caught in this and are affected by it is in the schools themselves, So it's just a few areas I think we need to do a bit more work on. Yeah.
If I might just very briefly, I think maybe as part of maybe the overall work of the group that the education sector is an important area in this. Like from a HSE point of view, we work with schools, but we also have to be conscious of our role and the limit of our role. And at primary school level, we have to be conscious that they're the experts in the area and they also have the relationship with the young people. But what goes on in school will certainly impact in community and at home. So we'd be supportive of it, but we need to recognise the role that the education system also has in this.
Thank you, Mr. Ryan. Deputy Buckley.
Thank you, Chair, and I want to thank the witnesses for coming here today. And I just want to put on the record, just to acknowledge all the fabulous work that's been done. But sometimes these committees are trying to find the gaps and try and fill them. And I'm going to be very frank, as I always have been. And a basic question first is, do you actually genuinely believe that things have moved forward in the last 10 years? Right? And why I ask you that question is, Mr. Ray mentioned a while ago about the consultant multidisciplinary teams. And through the information I had received recently, even the HSE clinical programme that was announced in December 2015, there's no lead has been appointed in that. We're now September 2019, and the clinical programme, that actual programme doesn't appear on the HSE page anymore, and I've been told that it's been moved to what's called the HSE Service Improvement Board, right? So you're talking from 15 to 19 to try and move things forward, and this is, I suppose, on the dual diagnosis predominantly, and we've done nothing. And yet, you go to New Zealand, and you have the Kiwis model, as they call it, and the government set up an inquiry into dual diagnosis. 6 panel members went out, asked 5,000 people what was needed. They produced their report, and the government accepted majority of the recommendations made about the budget and agreed with the budget allocations, all completed in just 15 months. Do you feel that we're just plodding along here? Because I feel it isn't all the years. Well, the short number of years I've been here, but in my background in mental health over the last 15 or 16 years, I feel like I'm listening to the same things Groundhog Day over and over again. I've heard about the recruitment and retention. I've had it inside in the floor with on Taoiseach. I said, we're training nurses every year, and the HSE are not giving them a contract. So we're shoveling snow while it's still snowing. Why are we not giving them a contract? But yet we can get in locum, we can get in agency staff that actually costs more. We also have been told over and over again, 700 vacancies within the mental health services, yet we're training people within the mental health services, but we're not taking them on. It absolutely does not make sense. Certainly, if you go back to the Vision for Change, we're 13, 14 years ago now, and even the review is nearly taken that long. Plus there was a sideline or parallel view with the Future Mental Health Care Committee looking at this. Nothing has moved forward. You'll hear about the worldwide crisis, but why hasn't anybody in the last 10 years come up with a plan to recruit, actually train and recruit them and retain them? In the last 10 years, there's only been 68 additional posts filled within the mental health services. In 10 years, 68 additional, where we're facing 500 possible vacancies within the next 2 to 3 years now because of people retiring. So there's going to be a massive, massive shortage. You spoke about capacity. We're not going to be able to do it. From my own information on PQs recently, we have a €19 million underspend on recruitment within the mental health budget. It's absolutely ludicrous. I had a cousin of mine who just emigrated to England because she wasn't offered a contract. Now, a lot of these people like to stay in Ireland, work in Ireland, pay the tax in Ireland, be close to the family in Ireland, but there doesn't seem to be anything positive. This is not a personal attack on you. I need to get this on the record because you have managers above you. I need to get this to the top, that they will buy in, that there doesn't seem to be a positive drive. It seems to be tick and box exercise and move on. And to me, you'll be on about it, Chair, on about the fake news. We don't have to go to America. We don't have to go to London. I feel like sometimes when we're in committees here, we have it here. 55 million is not the additional monies that was allocated last year within the Mental Health Service, because the HSC in their own report in the IV room did a report and it showed 35 million. So somebody is being spun lies, and it gets very, very frustrating for me when I'm listening to you're trying to do your best, but you don't have to seem to have the proper information. And I've said it before, if you're going to bake a cake, you need all the ingredients. And there's no point throwing in half the ingredients and expecting the cake to taste the same. It's not going to work. So going back to my original question, genuinely after what I have said there, do you feel yourselves personally that you feel restricted? Because I can understand, look, you've spoke about the models of care changing, yes, but the demands on the services, I accept again, have increased, whether it is in the youth, but also in the disability section. And we have a massive ageing population coming on, rural isolation, we're losing GPs, everything seems to be going in centralised into the A&E sections, you're being overcrowded. But we're listening to this over and over and over, and yet nobody within, whether it is government fields or within the top bases of the HSC or where the two of them can actually sit down and say, come here, we need to come up with a plan here, and a fairly rapid plan. Whatever it takes it, we need, whoever we train within the service, we need to retain them. Thus, how do you retain them? You offer them a contract. I can't understand it. And a recent PQ I had as well, and I'll finish on this one. And it was about CAMS again. And I put it to all of you again. And just an honest short question I'll do. Are you genuinely satisfied, dissatisfied with the way CAMS are going? Because again, it's the misinformation that goes out about it. And you spoke about members of CAM teams. Very simple. We'll just say it's 11 aside. It's 11 in each CAMS team. And we're going to set up a Premier League of 10 teams. But we can't run the league because Team A has 11, Team B has 5, Team C has 9. So it's not going to work in the system. Do you understand me? So it goes back to, why can't we? You have the demographic area. Cork is a fine black spot, so as many other spots, and I'm not going to pick it out, I'm going to use it because I'm from Cork. Right? The demographic says the incidence of suicide, self-harm is high. Let's put in a pilot project. Let's fully resource and staff it, thus facilitating everybody, all of you, in your respective roles and everything, because you all have to work as a team, and start reducing the figures, thus showing that this model works. You've now invested in a model that works, therefore you can replicate it around the country, thus reducing everything. But at the moment, it seems to be, we'll try and do everything together. We don't have a plan A, because the plan A has actually been shelved now for the last 4 years, and we're going to put it into somebody else's department to talk about it. But in the meantime, we're losing our nursing. We're losing people to suicide, unfortunately. We have information, I mean, what have we, 76 beds, 23 of the 27 were vacant in July. And I got that from PQs, and I have it here if you want it. So it says, while the beds have increased, there are only 75% of the level recommended by 75% by Vision for Change 13 years ago. But in reality, if you take the 23 or 27 out of it, 13 years on, in our CAMS plan, we're only at 50%. So if you start putting out all these figures, it makes no difference to the people that are trying to access the service. And it is access. And I'm telling you from my own experience, and I was late even yesterday because I had to meet an individual in my office. It was a crisis case. During the so-called break, 4 times I had to get an individual, a young man, 4 times, had to get him arrested for his own safety. Now, in fairness, and here's where it is, and where the system does work, and I will give credit where credit's due, I did contact the crisis team in Cork, and I have to say, above and beyond, absolutely brilliant. But there's one section of a model that works. So what I'm trying to say here is, and again it goes back to this, I need an honest answer here, so management and government can hear. Do you genuinely believe 13 years on, Children's Committee, Health Committee, Future Medical Health Care Committee, Sláinte Care Report, and in fairness, it's done in a very, very short time. And we're at 50% of what we need in CAMS. We're 700 short on positions within the mental health service. We're facing a dilemma of losing another 500 within the next 2 to 3 years. We have a 19 million underspend in recruitment because we can't pay them, but yet we have money. And we have misinformation every year because his original figure was 84 million, 29 million that was spent the year before. The total was a total of 55. When you get the HSE report, it's actually, what did I say, 35 million. And we're all saying we're trying to do our best, and yet we're back to phase 1 again. What is our plan for next year? So that's my spiel on it, and why I want to say that is not pick on ye. I need your management and your top brass to hear this, to talk to the government and say, look, let's stop trying to fix everything all in one go. Let's try and do it properly. Let's give ye, each one of ye, your maximum resources. As you said, whether it is Lindara, Aishling, whether it's a jigsaw project in Galway. I mean, I can go back, I think it was something couch, about 12, 14 years ago. Squeezy couch, I think it was in Galway when I started. So, just a brief statement to say, if you felt it, are we under-resourced? Is the plan plodding along? Is there actually belief that there is genuine drive when you can see the New Zealand model there, they can do something in 15 months and actually drive and come up with a 10-point plan. There's actually a video to show you what they're doing there now. It was patient-centred, and here we are. I'm here 3.5 years. I'm sitting in front of some of the same witnesses. I'm sorry about this now, Chair, but I'm hearing the same thing over and over again. If 3.5 years, 3 years ago, we had flagged about the recruitment, if they had retained the nurses that they trained the last 3 years, surely we possibly could have maybe 400 vacancies within the mental health service. It wouldn't be as bad as 700, but that 700 figures there with the last 3.5 years and nothing has happened. And I feel like you're coming in here sometimes, and it's like, as an old lady said to me one time, it was like a penance. You got a bucket with no ass in it, you were sent to the Red Sea and told to empty the sea with it. You're never going to get to it. You'll have a bucket, but you won't do anything with it. We seem to have budgets, and nothing seems to be done with it, to the fact that I think it's being misconstrued, is the word, and again, it's not on ye, because you'll take the responsibility, but it's your managers above you, is the people I want, and I'd love to sit down with them and say, look, tell us the truth. If there's mistakes being made, and there is mistakes being made, and this is not the platform for it, but believe you me, there's a lot more within the mental health services that when they come out, I think a lot of these areas, and I think Deputy Sherlock tipped on it, where a lot of these places are not fit for purpose, people are not being disciplined for X, Y and Z, but as I said, that's a different story. My priority here is trying to get people, get a preventative measure in here, but we don't seem to have any joined up thinking, misinformation, the same stories. We're doing it today, we'll be doing it again tomorrow. We're short a few bob. We'll tell the government or tell us the truth, throw it up on the table, black and white, and we'll go and tell them on your behalf, because as I said, I know, no doubt you wouldn't be in the position unless you were passionate about it and you want to change things as well. But you cannot change it. As I said, you can't be the manager of the football team with 6 on your team and the next person has 11. You're at a disadvantage straight away. And if you're not going to get funding from who supports your team, you're going to be relegated and that's going to be gone. And once it's gone, it's gone. And it feels the same with these services. Well, everything has the best will. With all the things that are there, I'm seeing it day in, day out. No access, being turned away. We're overstaffed, or we're over-subscribed. We're understaffed. That's closed. We're sorry. It's not a reflection on you. And for the frontline staff who do their best as well. But the point I'm trying to make here is, please, let this go back to head management. And even if they just text the Minister for Health, the Minister of Mental Health and all the people, I don't care what it is, but tell them the truth and say, look, the time for talking, I think, is long gone by. There's a different class of politicians here now that actually do give a damn. And we're not talking about statistics and percentages, we're talking about people, and you've seen it yourself and you've heard it from other witnesses. One person dies directly, 42, 45, flutters out about 220 odd people. That could be a rural community just devastated in just one go. That's happening every day. We've seen the WHO report, I think it's every 40 seconds in the world at the moment. Somebody dies by suicide or contemplates it. There has to be a crisis, there's something going wrong. So, it's just a very thing, do you actually genuinely believe that we have moved forward in the last 10 years?
Chair, so I've worked in the mental health services for 15 plus years, and I genuinely believe things are getting better. Where's the evidence for that? Well, if you look at, we had 6 beds in 2006 for CAMS. We have 74. I accept at the moment there's 48 open. I accept that.
Perfect.
We have 70 teams. I can trot out any of those statistics, but frankly, it's much more about the way in which we try and look at mental health over the last 15 years that has changed. We have a regulator in charge now in the Mental Health Commission. We have a Mental Health Act which was implemented in 2006, reviewed in 2011. We have a Vision for Change policy document which is recognised as one of the most far-seeing across the Western world. So there's a lot of basic building blocks, but mental health was coming from a very low ebb.
Yep.
Anybody that has seen the Behind the Walls programme a number of years ago would have looked at what was happening in this country, and things have changed dramatically. Obviously, we're still on a journey. I'm in contact with people who are in Europe who look at what we're doing with service users, and they can't believe. We have a service user who's on my management team, whose sole responsibility is he has to represent the role and views of service users on my management team at national level. No other division have that. We have 9 area leads for mental health who are service users and carers and family members. No other division of that. So we have forums, we have peer support workers. A lot of the things that, from a caring perspective or from a recovery point of view, are in place. The issues that you raised there, to just try to put a little bit of context, the 55 million. So last year there was 35 million, and what happens is you get 15 million of that in the year, and you get the following 20 the following year to be the full year cost of that first 15. So that's the reason why the 55 can be confusing at times. I can assure you it confuses me at times because I'm saying, I thought we got this. The other thing is that the 89 million is when you add in things like consultant back pay, and annual this increases. So it's not going into a service. Exactly.
Correct. Thank you.
The 35 is to go into the service. The issue I said earlier to Deputy Neville was that all that money is spent in mental health. It may not all be spent for the areas in which it was given.
Yep.
And I acknowledge that. The issue you raised about nursing contracts. So if virtually every area of the country has nursing deficits. So we have a process by which if somebody leaves, there is a process by which the head of area sends it to me, to us national director to be signed off. If somebody leaves and they're a nurse, we have never stopped a nurse being replaced. We try to provide contracts for nurses who are graduating. And remember, as I was saying earlier, we have an extra 60 graduating in 2020 from mental health money that we've spent, not from education money. So that's 350. It'll go up to 420 the following year. And then we would hope that that will address some of the gaps, because I'm conscious we have new developments every year. We try to fill those. They can sometimes create gaps back in the services from which they've come. So it's a churn, and it can be catch-up. But just to reassure you that that 55 million, that's the reason, that rationale for that. The nursing contracts, we're as you may know, I'm involved with the Central Mental Hospital. So we're offering contracts now, permanent contracts, to graduates, because we need them to open the new hospital in 2020. So if there is a situation where a person wants a contract and they're a nurse, they will get a contract. Our difficulty at times is AHPs, allied health professionals. When we're trying to make balance between our budget and our activity, we also have to be cognizant of the resources that are allocated to us. And you're right, that is above my pay grade, but that's being open about it. I have to be straight and say we advocate each year on behalf of mental health services. We put a business case together for additional funding. Additional funding has been allocated. We have struggled at times to spend the money in the areas in which it has been allocated. Dual diagnosis is one, early intervention psychosis, perinatal, mental health, intellectual disability. They're all niche areas where it can be difficult at times to recruit the specialist staff that are required for those. And sometimes what happens is that the staff who are going to take on those posts are actually coming from our core services, which means you create a deficit back at base, and it becomes one of those circular difficulties. So that's my view. A lot of the things that, as you say, we don't talk about in circumstances like this, which can become quite demoralising for people who work within the system, because they'll hear a lot of negativity, when in fact when you speak to lots of service users, they say, yeah, things are, but they're improving, they're getting better. Our facilities are still not, as Deputy Chairman said earlier, across the country not as good as they should be, but we have made some progress. So I suppose in order to try and keep going, you have to try and believe that things are improving. And for example, even with Jigsaw, who are NGO colleagues here, there's, I think, over 10 million has been invested in Jigsaw each year from HSE funding, which sometimes, and we don't make a big deal about it because that's the way it is, but sometimes people say, well, you're not doing anything. The fact is we fund organisations without our name hugely up in lights, because then people say, well, they get confused. We don't need to do that. It's about delivering the service. It may be our service that we're working with our partners, but it doesn't actually matter as long as people are benefiting from it.
Thank you. I suppose the question you posed really was, has anything moved on in 10 years? And I suppose if Jigsaw has one message to this committee, it's about early intervention. And I would say, I think as Jim has pointed to, 10 years ago, there was no such thing as an early intervention youth mental health service. So we've come a long way. I won't borrow the old phrase about all the work.
And as I said to start, I totally acknowledge it, and I totally respect your honesty, and that's what I want, because I need people outside of the realm to know that you're not being fully supported either. And ye want to do it, and as I said, and I'm actually going to go on record here, Chair, and you'll laugh. My wife will actually kill me. I'm going to say this line: prevention is better than cure. She said, she'd be black and blue every time I use it, but prevention is better than cure. And we are a reactive society at the moment. We have to change that to a preventative society, and that's why I acknowledge all the work you're doing. And that's why I asked the specific question, so ye can make the appeal as well, to say we need more to do what we set out to do.
Absolutely, and I think, in some ways, and I think sometimes actually the discussion and the questions here are reflective, I suppose, of the focus that we've had as a nation on the more acute end of the spectrum, which is important and needs to be resourced, and absolutely is overstretched at the moment, as I think, has come through the discussion. But I suppose as a nation we need to move our thinking, and we need to move our thinking and our resourcing upstream, I think, is the key message that Jigsaw would have. And I'm always loath to make parallels with physical health, because mental health, it's different, and there are complexities to that. But if you think of, as a country, we wouldn't countenance having a system where there wasn't a comprehensive primary care system for mental health. We wouldn't countenance having a system that didn't have, a vaccination programme across the board. So while we've made loads of progress, and we have Jigsaw services that we're delighted to have, and are very grateful for the HSE support in delivering those, we're only in 13 communities. We want to be across the board, and we need to do more than just offer the services that we're offering at the moment. Your other question was, is that system under-resourced? I think the fact that, as been pointed out earlier on, mental health remains the poor relation in the overall health budget, and early intervention, at the moment, it's coming along, but it's still the poor relation in the overall mental health budget. So I think, we know from our work in Jigsaw that very many of the young people, the figure earlier on that I think you referred to, around the 33%, that could seem overwhelming and daunting. You could think, how are we ever going to meet the needs of those young people? But we know that very many of those young people will never need to go to a specialist service if we have a comprehensive prevention and early intervention approach. So some of that can be online, some of that's in their own communities. They may never even need to cross the door in Jigsaw if we empower and equip their parents, their teachers, their sports coaches, their scout leaders, the people around them. Some of them hopefully will have their needs met through online supports, through information and guidance, through group chat, through one-to-one services there. Some of them will need to come through Jigsaw's doors, and some obviously will also need to go to the specialist services. But the key message is getting in as early as possible. And that's, if we're comprehensive in our early intervention approach, that's how we're best then able to support the more overstretched, acute end of the system.
Thank you. Just to answer, maybe to say what has changed. As clinical director of a service now for over 13 years, yes, there's been, so I can speak what's on the ground. On the one hand, you look to the positives. We've investment in a new purpose-built community service based in Cherry Orchard Community Building. In there, we've been able to develop. Last month, there was the official launch of our community eating disorders, specialist community eating disorder service. It was the first. A second team is starting in Cork as part of the clinical programme for eating disorders. We've established a specific ADHD pathway team within our service. In Kildare, where we cover in Kildare West Wicklow, where there once was one team, we now have 4 and hoping to develop 5. Having said that, and then on the inpatient side, as we had an inpatient unit in 2006 that had 6 operational beds, and in 2015 we opened our brand new bespoke inpatient unit, which has won Architectural Design Awards, which has had again, visitors from abroad have been hugely impressed by it. But in a sense, what means more to me is the feedback from young people and families about it, which is even more important. The experts. And their feedback. And it is, again, you visited there, you've seen the unit, it's all, you're kind of ensuite, single bedrooms. We have a sports hall, we have a gym, attached school, we have parent accommodation. All these things are hugely important. On the one level, they're the positives. What are the frustrations on the ground? The frustrations are that all our teams are not at the full complement. So some teams have the complement of disciplines, but not at the number 11. And then we have other teams that aren't even at the full complement with regard to multidisciplinary. Some of this is funding for new posts. Some of this is retention of staff, be it maternity leave, be it leave, to take up posts elsewhere. Then the delays, and even when a post is approved in refilling a post when somebody leaves, there can be a significant gap. And the frustrations are that we cannot provide the level of service. So there's a lot of, as a sense, as I said, pride at the progress that has been made, and then frustration that we're not able to deliver the service. And we know in the feedback from families that they're very appreciative of the service. But again, it's the importance of that response being a timely response. On the inpatient side, in a sense, we are the unit which we strive to have maximum capacity. I think the way our unit has been designed has facilitated our capacity, and I think if you look over since we've opened, we're averaging between 80 to 90% occupancy. But there are times we have not been at that, and that may have been for case mix reasons, and at one point we had to close half of our unit because of staff shortages, and we are running with significant vacancies even within the inpatient setting. So it is that kind of, on the one hand, there has been progress, and the frustrations are that we require additional funding to fund new posts to build the teams up to the recommended level. The other frustration can be that that we're running vacancies where really the issue isn't funding, it's difficulty recruiting in particular specialties. So I think on the one hand, I see there's been, significant progress. I mean, for example, we are involved in the planning and of the inpatient unit in the new children's hospital, which will be under our governance, and that will have an 8-bedded specialist eating disorder unit, and we will have a 12-bedded unit. So that's another 20 beds. There's 10 beds will be coming on stream of a kind of low secure adolescent, or that kind of unit, which is part of the redevelopment of the National Forensic Services. We are hugely compromised here because we don't have access to that low secure for those who need a higher level of acuity and who need that particular kind of environment for their care needs to be met. And then if you have to manage such young people in our units, that is going to in turn impact on our ability to deliver services for others. So I think we can see the frustration is, I think, from being on the ground although there has been progress, the progress hasn't been at the level at the speed we would like. And some of these, you could say, are down to funding issues, and some of them actually are not down to funding issues. But I suppose overall, I think I can think of the unit where we did work as our inpatient unit all that time ago. You brought in families and you apologised for the facility. Yeah. You now come into our unit and you're very proud of showing families the unit and the physical environment. But really, it's the environment is only one part. You need the staff to deliver that. So you need all of those levels. So on the one hand, there is progress, but I think, as I said, be a teamer, staff on the ground at all levels also feel that kind of frustration that we're not able to provide this, a level of service that we would wish to.
Lovely. Thank you
very much,
Thank
Professor.
You, Chair.
Thank you, Deputy. On behalf of the committee, I'd like to thank you very much for your presentation this morning and this afternoon and answering the questions so forthrightly. We're just 2 hours into our discussion now. The meeting of the Joint Committee is adjourned until Wednesday, the 9th of October, 10 o'clock, when we will continue with this subject matter. Thank you very much.